Hey, and did you know I'm currently accepting new patients in New York, offering both in person and telehealth visits? And I also provide telehealth for patients in Michigan, with North Carolina coming soon. And I also offer coaching, both intimacy coaching and menopause coaching, nationally and internationally. So look us up on www.femvhealth.com. I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about sex in midlife. But before we get into it, a few things I want to make very clear. One, we are not giving any type of medical advice. So if you have any questions about sex, midlife, or all of the above, make sure you go speak with your healthcare provider. And this is no advice on religion. So if you have any questions about your religion, make sure you go speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So today I am super excited to have on with me Dr. Maria Sophocles. And Dr. Sophocles is known for tons of things as I was doing my own research on Dr. Sophocles. So I will let Dr. Sophocles introduce herself for all those people that are listening and watching out there. Dr. Sophocles, please introduce yourself.
Okay, I'm a 30-year board-certified OBGYN, but I focus on gynecology, on menopause, on sexual health. I'm a sexual counselor as well as a gynecologist. I'm an author, I'm a TED speaker, and mostly now I practice a couple days a week in Princeton, New Jersey, but also virtually. My virtual practice is international, so I have a lot of international patients and patients around the US in different states because I'm licensed in many states, which is really helpful because a lot of women with sexual issues, especially in midlife, don't really know where to go to for help, don't want to give themselves permission to even get help. And so often they find me from all different corners of the country and the globe, and we can do quite a lot virtually. I'm working on a documentary film right now called Hot, which is about sex and women in midlife and the sexual journeys that women go on, and everything from their frustrations, fears, angers, and shame to a bit of a renaissance and a reclaiming of our sexual selves. So Hot, the documentary, will be out, I hope, next year. And that's kind of about me. I've done research with the NIH. I've been an academic clinician. I've been a private practitioner. I work a lot with governments trying to get reproductive health and menopause in the workplace policies enacted. I think I changed the New Jersey Constitution. That was a really important thing for me to achieve so that women in New Jersey have better access to contraception. And right now I'm doing a little more work on menopause legislation statewide, trying to get more rights for women with menopausal symptoms so that they are still valued at work and can keep their jobs. So there's lots of work to do, as you know, you and I know, and there's lots of advocacy out there. I'm enjoying blending clinical practice with a lot of podcast appearances and a lot of advocacy, and trying to get my book, The Bedroom Gap, into the hands of as many women as possible of all ages, stages, races, religions. It's a very universal kind of topic, which I think we'll get into.
Awesome. Well, thanks so much. So I think you started to talk about this a little bit. So what led you to focus your career on menopause and sexual health?
Well, really, the aging of my own patients and my awareness that I was not adequately trained. I trained in very classic Western medicine tradition, and I thought because I was well trained that I was, destined to be a great OBGYN. And I didn't realize that my own training was lacking in menopause care, just like almost all of the clinicians I trained with in the 90s. And as my patients start aging and coming in with not just hot flashes, but joint aches, brain fog, depression, anxiety, shoulder pain, palpitations, all those things you and I see, I mistakenly thought they needed neurologists and cardiologists and orthopedic surgeons and psychiatrists. And so I got myself trained about 20 something years ago as a menopause clinician, started being a part of the North American Menopause Society, started mentoring other physicians in that, and have spent the last 20 years really developing not only a practice in Princeton, New Jersey, which served about 30,000 women from all over the region, but trying to spread the word to other clinicians and go to medical schools and get training, better training for clinicians. So I got into it almost through the back door by realizing that I needed better training and my patients sort of deserved better. And I really enjoy it. I really feel like we can make a difference in people's lives at a very vulnerable time. I used to feel that way about puberty when I first started because I felt like teens were sort of one foot in the pediatrician's door, one foot in the GYN door. And now I feel that way about perimenopause and menopausal stage women, that it's like this life chapter, right? Where so much of our metabolism is changing, our biology is changing, where our ovarian function is changing, and that unleashes this whole host of issues. And it's been very, very under researched, understudied, and under taught to clinicians. I think as someone, doing what you do and also in the academic world, you must see the same thing.
Yeah, absolutely. I mean, definitely, we are not taught. And I think that even a few years ago, I was part of an academic institution and they didn't teach their clinicians anything about menopause or sexual health or anything like that. I mean, it was hard enough just getting them to talk about postpartum depression with the residents and then also doing the PHQ-9 and all of that. So,
Right.
forget menopause and perimenopause and sexual health. I mean, that was nowhere to be found. So, absolutely. That hopefully, I think now, perhaps as the pendulum swings and more people are becoming interested in menopause and perimenopause and midlife health, that I think hopefully more residencies will also, start teaching their residents.
Yeah,
But
I think
definitely,
so. I
there was
think
none of
it's
that.
swinging, it'll happen, but, there's menopause, and then there's the sexual fallout from menopause, and then there's sexual health overall, and I think sexual health is still not truly valued as one of the pillars of health, as a marker, in a way, for your overall health and happiness, and so I think that's just another layer of, healthcare that needs to come out of the closet, so to speak, and I think it's especially poignantly still taboo and shameful for women. And I think that, so it's one thing to have menopause having its moment, but I think it's a different thing for women to really look in the mirror and say, am I sexually satisfied? Is this the sex I want to be part of? Or am I just having sex for my partner because society sort of has told me he is entitled to it? I mean, we have the same issues in same sex relationships too, but most of my patients are heterosexual, and most of my patients feel that sex and sexual enjoyment is something that men are entitled to, but not necessarily women. And it's been incredibly stunning to realize how pervasive that thought is. And that's kind of what led me to write this book.
Yeah, 100%. I mean, I think that, every time I see a new patient, she'll tell me she has no libido at all and that, she's really struggling. And then she'll add in there that, well, I feel bad for my husband because I feel like he really needs it. And as if she doesn't need it, right? Like as if like her desire, her pleasure doesn't really matter. It's all about her partner, her spouse, whoever, but not about her. So I agree with you 100%. I think that that is something I hear all the time, and it's really important to change that narrative.
Yeah, and I spent a lot of the last decade or so going around the world to 5 different continents, interviewing women, talking to women about exactly this. And the universality of this is stunning. Whether someone was in Morocco or Ghana or Buenos Aires or Banff or Paris or Madrid, I found very much the same thing. That women, whether they were cleaning houses or running a multinational company, in the exam room or in a cafe privately talking with me, they would say, well, I feel bad for him. It's for him. And so I would say, why do you feel bad? And they would say, well, men have needs. And I thought that was another interesting phrase. Like men have some need that like they're going to be unhealthy if they don't satisfy this need. And so our role as pleasers, givers, servers, and females is just to
Is to serve them.
by that need, right? And so when I was researching the book, I started really digging into that, and I found that this is at least a 4,000-year-old story, 4,000-year-old story of what we call the androcentric sex model. That sex is for men and for male pleasure and for procreation of the species, and that you and I and all our peers still have some little umbilical DNA thread of that story that just somehow is in us. Because I think for some women, yes, they learn that from their mothers or their grandmothers or their aunts or someone who sits them down and says, you've got to please him, it's for him. But I think it's deeper than that, and I also think it's more widespread than that. I think Hollywood teaches us that. I think porn teaches us that. And I think the way we value women in healthcare with this $1 trillion healthcare disparity teaches women that in its own way. Just the fact that we don't have much funding for female sexual health, and we have different levels of research and development, even of medications for male sexual health and female sexual health. I just think all these are examples of that common thread of sex is for men. And so I think people like you and I would love to change that narrative if we can.
Yeah, absolutely. So I'm so curious about that. So when you were talking about this androcentric model, I'm wondering if that has some religious background to it. So in Islam, Islam is, well, so I'll tell you, my story is that like I was, a few years ago, not too long ago, I would say about 5 years ago is when I started doing this podcast. And I can't even believe it's been 5 years, but it is. And, but before that, I didn't know that Islam was a sex positive religion. I was raised very conservatively. And so I didn't know at all that it
And
was
you're
sex
Muslim. I mean, imagine how little non-Muslims know
positive.
about it. That's
Right,
crazy.
right, right. So I'm Muslim and right, and I didn't know Islam was sex positive. And then I learned that from actually this author who's amazing, and he's been on my podcast a few times,
Mm.
Habiba Kande. And he wrote all these books and stuff like that. And he wrote a book called Islam and Eritology. And I was like, what? What the heck is this? Right? Eritology and Islam. So he goes into deep into the history and what happened pre-Islam, after Islam and this and that. And so Muslim women actually have sexual rights in Islam. And that is that, women also need to be satisfied in a relationship. And also that if you are not sexually satisfied in your marriage, that's actually a reason that you can get a divorce. Isn't that interesting?
Wow, very
Yes,
interesting. And when
right?
did this began with the beginning of the practice of
Islam.
Islam? Yeah.
Yes. Yes,
Wow.
1400 years ago.
Right.
So
Wow.
the thing is that like, Muslims, I don't know. I don't know my own religion in this sense. I don't know my own, tradition and things like that. And so I had no idea. And what I think is really interesting is that like, with the colonization that happened in South Asia, we were colonized by the British. And so the British brought a lot of their puritanical values and morals. And, so basically they then imposed those puritanical rules on us and made us feel like sex was wrong, dirty, shameful. And
Right.
so we started to believe that as well. And then, that's how all this shame, I feel like, comes about, especially for South Asians. I'm Pakistani. And so I feel like, there's a lot of taboo and stigma and shame around sex, in my culture for sure, 100%.
And did that come,
Um,
you think, from the colonization in India and then into Pakistan, like that,
yeah,
right?
absolutely.
Yeah.
Absolutely. Absolutely. So, I mean, like, Indians had, right? Hindus had the Kama Sutra. And
Yes.
that's very sex positive, right? But then when you talk to some Indians now, right, there's still that shame, stigma, taboo, that it's wrong, it's dirty, all of this stuff, right? So where does that come from when you had this whole rich history of eritology yourself, right? So that's really something that's interesting and really, I think, worth looking into. And in fact, Ishwish actually one year had a lecture. I'm not sure who it was by, but it was a fellow Ishwish, I think she was a Ishwish fellow that talked about Hinduism and sex positivity. And I think it was a few years ago that I was there.
Yeah,
But anyway,
yeah,
she mentioned that she was also talking about the colonization and how, it was after that that Hindus also became, very, that became
more.
stigmatized. Yeah.
Yeah,
Yeah.
it's kind of amazing though if you think about it that 1400 years of sex positivity could be shaken by something as recent or minimal, right, as the British coming in and colonizing and building roads and bridges and doing things in a way. In another way, it kind of makes sense. They've come in, they're going to impose their values. But I struggle with that still, how those values would stick so much that you'd get this deeply entrenched belief of sex
Yeah.
positivity that would sort of flip like that. Like I still have
Yeah.
trouble
I
squaring that
think,
circle.
yeah, 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 sure. And so I think also, you have to understand also that there's this thing called colorism, right? So that also came about when once we were ruled and we were seen as, right, to somebody who is white, and it's still it's pervasive and definitely in
Yes.
Pakistan. Somebody that is a lighter skin is seen as more beautiful than
Yeah.
somebody that is darker skin. And when you look at their, in fact, I was my one of my Instagram reels, some company in Pakistan used it to advertise their face whitening cream or soap or some nonsense like that. And yeah, without me knowing. But I mean,
Oh, I'm
that,
sorry.
so that also plays into from, colonization. So there is
Yeah.
a long history with
That's
that. I
true,
mean,
and it becomes a sociocultural ladder, right? And so if there's pressure to be higher on that ladder and your skin color does that, and you can then espouse more puritanical values as part of your new identity or your more white identity, I that makes sense. I mean, that's unfortunate. They
yeah,
actually
yeah. I mean, there's a lot of things that happened with the British. There was forced starvation. There was a change in our genetics. We have increase in cardiac risk because of that. We have an increased risk of diabetes. Where so there's a lot of that. But I want to actually go back to what our topic is. And so, how do you think that hormones affect? And we've talked about this. Actually, I've talked about this a few times on my podcast, but kind of wondering what your take is on this. Is how do you feel that hormones affect, of course, desire, arousal, orgasm, and intimacy?
Sure. Well, all of those parameters of sexual function are multifaceted. So they're not just purely related to your hormones. They're not absolutely unrelated to hormones, right? So your arousal, your desire, your overall interest in sex is not just a product of where you are hormonally, puberty, pre-menopause, perimenopause, or postmenopause. It's a product of how you value yourself as a sexual being. Are you partnered or not? Are you attracted to your partner? Do you value sex as part of health? Do you value sex as part of your good relationship? Do you know your body? Do you know what gives you pleasure? All of these things set you up for a more successful relationship with sex. So you're going to be somewhere in there, right? Either super sex positive yourself, based on what were your family values, what were your teachings, what's your I don't mean education level in general, but what's your education level about sex and talking about it. So all of those things can impact arousal, desire, ability to orgasm. Now layer on top of that whether you're in a, we'll call it like a hormonally stable time in your life, let's say age, you know, 18 to 38, when you mostly have pretty predictable periods, predictable rise and fall of estrogen, followed by a rise and fall of progesterone, followed by a period, your fertile years. But certainly from late 30s to early to mid 40s, you could become perimenopausal, which, as you and I know, is when the ovaries are still making estrogen, progesterone, and testosterone, but in a more erratic way. And that erratic secretion can have not only hellish effects on periods, but can affect our overall sense of well being, our anxiety, depression, PMS. It can really wreak havoc in the brain, which can really impact your even interest at all in sex. then after you're perimenopausal, the ovarian function basically ceases. It sort of plummets to basically zero. And when you have that loss of testosterone, estrogen, and progesterone, but particularly estrogen and testosterone, we know this has direct effects on the brain, including the parts of the brain where sexual desire is generated. We know this also has direct effects on our genital health, including our clitoral health, including things like the vibrancy of nerve endings around the clitoris, including the rate of blood flow to the clitoris. So as we age, that rate of blood flow changes. And just like when we have coronary artery disease, if there's plaques in our arteries and the blood flow to our heart is not as robust, our heart health isn't as robust, our clitoral health can suffer. And you and I see this because women will come in and say, my orgasms are kind of meh, like they take a long time and then they're kind of a instead of a scream, they're a whisper. And women are really frustrated. We know also that the lower genital tract, that the vulva and the lower third of the vagina are full of both estrogen and testosterone receptors. This is embryologic. This isn't rare. This is in all females with the vagina. And we know they're very responsive to topical estrogen and topical testosterone, also to systemic estrogen and systemic testosterone. But we happen to know that the topical formulations are crazy safe because they're very low dose and they're available in estrogen's case via prescription and in testosterone's case via prescription in a compounded way. We don't have an FDA approved testosterone yet. So our hormonal milieu, the amount of estrogen and testosterone that our genitals get exposed to does help us be able to respond to being aroused. Notice I didn't say to desire, to arousal, because for so many women, they actually have to get aroused before they have desire. We call this receptive desire. And it almost flips the script on what you and I were taught in medical school and what many, many listeners might think, that you have to have some basic level of desire and then you get aroused and you keep getting aroused and then you have an orgasm. What we know now is that for many women, they actually become aroused first. They're watching, some hockey show on Netflix, or they're reading some juicy book, or their partner is kissing their neck or stroking their back or their nipples or something, and they're feeling changes in their heart rate, and their palms are sweaty and their genitals are responding, and they find they're aroused. And once they're aroused, desire follows naturally after that. So I think all those things are important to understand. I think the effect of the lack of testosterone and estrogen, we know it's not only genital, but it's in the brain. But it's really not as simple as just, here's your hormones, now you're going to have desire. I never give women systemic or topical estrogen or testosterone and say, do this, you'll be fine. I always make sure that they're combining whatever it is I end up giving them with bringing erotic content into their brain, whether it's by touching themselves and teaching them about masturbation if they've never done it. My book talks about that, how to begin, or touching their partner and being aroused through touch with the partner, or reading a juicy beach novel, or listening to an app like Quinn where they'll read you erotic stories and that erotic content goes into the brain, or visual. When we say porn, most women go, ugh, and porn has a really negative connotation for women, deservedly, because it's so degrading in some ways. But there is female forward porn. There are directors like Erica Lust. There are websites where the visual adult videos are arousing to women without being degrading, where orgasms can happen without penile penetration, where it's things that women can get turned on seeing. So I would say, if you are wishing you had more desire or more performance in the bedroom, and you could find a clinician like you or like me or others, you shouldn't really be just looking for a magic prescription that's going to make everything great. You should be thinking of it as a holistic kind of multimodal project, if you will, where you're going to be responsible as the patient for bringing that erotic content into the brain. And then if we can optimize the hormonal milieu of your brain and your genitals, we're going to just enhance that even more. Does that kind of fly with how you treat as
Yeah,
well?
yeah, absolutely. So when I have women all the time that come in for decreased desire. And so I always tell them that it's, the whole biopsychosocial model, right? We don't give just hormones and say, well, this is, you're going to feel better now, because sometimes women don't, right? They still have so many other things that are going on. And biologically, you also have to look at, what's going on. Are they having pain with sex? Or do they have clitoral phimosis? Do they have vaginismus? Or
Or
what's
they
going on there, right?
diabetes, and so they have small vessel disease, and if you have small vessel disease, you may not have the blood flow down there that you wish you had. So it's right,
Correct.
it's a whole thing, it's a whole
Yeah,
thing, and so
yeah.
hard
So
in one podcast to kind of hammer all that out, but the good news is if women can find a clinician who's competent and cares and has the time to spend, they can really break it down and for many cases, at least improve things. You may never get to perfect, but I think for many women, they're really having like no sex at all. And it can be really relationship wrecking. I've had many, many women come in after their partner's already found a new partner, sometimes surreptitiously, or after the marriage has ended and now they're dating again and they're nervous because they're not sure what to do. And actually, I view this as a wonderful opportunity for sort of a life reset and to say, okay, let's see if you can be part of the sexual journey this time. And let's figure it out so that you're not just having sex to please your partner and keep a partner, but you're actually part of the joy and pleasure on the receiving end.
yeah, I agree with all of that. I think also, when we talked about that biopsychosocial, going back to that, I also want to know like what's going on with like anxiety and depression. And we also take a look at side effects of medications, and sometimes medications can affect desire. And then also, socially, right? We talked a little bit about that, but socially, if you've grown up with a lot of sex negativity, right? You
Yes.
have to at least go to sex neutrality before you can be accepting of some type of sexual stimuli so that you can then participate. If you have if you're a single mom working like 50 jobs and sex then all of a sudden becomes a chore, if you are not getting anything out of the encounter of sex, right, then you may also not want it there as well. And also, I was just talking to a patient today and she told me that, I have so many, like, when he's scrolling on his phone, to me, that's the biggest turn off. And he's always looking at his phone, right? So you have
Yeah.
to also understand what are your turn ons and what your turn offs are, and try to work and mitigate those, right? And creating that emotional intimacy also in a relationship really helps
Yep.
to increase the want, right? You have to want the want. And so a lot of times increasing emotional intimacy will then lead to physical intimacy, which can then also strengthen the relationship.
100%. And that goes for men and women. I have many patients that say, I don't think my male partner really cares. He just kind of wants to have sex, have his orgasm, and go to sleep. And yet, I've talked to a number of men who've said, actually, if I'm not emotionally connected to my partner, if we've been fighting or she's being really overly critical, or whatever, I actually don't want to have sex with her. I'm fine. I'll just masturbate. I don't want to. And that comes as a surprise to many women. So don't think the emotional intimacy is just for you. It's for him as well. And I think that's a really priceless bit of information. The other important thing about the term intimacy is that when we look at sex and longevity, right, the fact that being sexually active and staying sexually active actually has health optimization benefits, which we know now from studies that it lowers depression, lowers blood pressure, lowers anxiety, has health benefits. The part of having sex that does that is not actually the orgasm. It's not actually whether there's penis and vagina sex or oral sex or anything specific like that. It's whether the sex has intimacy linked to it. When sexually active octogenarians and nonagenarians describe that are healthy, describe their sex life, the continuous the part that is continuously seen is the intimacy, is that having that intimacy makes them want to keep having sex And by the way, when you have sex, you do release endorphins with orgasm, you release dopamine with orgasms. And we know that, believe it or not, those releases actually impact our ability to build and keep lean muscle mass. And you and I know that having lean muscle mass is actually critical for older people who are at risk of falling and instability. So there are health benefits to staying sexually active, and intimacy is the cornerstone of it. It's what makes you keep wanting to have the sex. So kind of cool, right? That
Yeah.
there
No,
can be some
absolutely.
cool health benefits even in advanced age to staying sexually active.
And I agree. I think that that's really important. The intimacy is always right, and the emotional intimacy is definitely so important in a relationship. So, you've done some work with around vulvovaginal health. Can you tell us a little bit about what you wish women understood about painful sex and whether it's part of normal aging?
Yeah, my my little teeny contribution was that in 2015, I pioneered the use of the CO2 laser in the United States of America. I didn't invent it. I just happened to be living in Italy where it was invented, and so was able to be the first to bring it over to this country. And then from there, I took that technology to 5 different continents, so doctors around the world could understand that using the laser in the vagina for sexual health, vaginal health, to regenerate collagen and regenerate blood vessels was a non medication, non hormonal way to achieve and improve health. We use this for women with recurrent UTIs. We use it on the vulva for women with vulvar diseases like lichen sclerosis. And it's been very nice to have made a difference in that sense. I mean, unfortunately, it's not covered by insurance, so it's hard to scale the benefit of that. And it's certainly in studies no better. It's not superior to vaginal estrogen or anything like that. It's simply an alternative. So that's one area of vulvovaginal health that I've been interested in enough to bring it to the United States. I think that vulvovaginal health gets sort of under trained again in residencies. So I see people all the time with severe vulvar disease and severe pain with sex that have been just given yeast infection medication for years. So again, we need to do better at the medical education level. But I think sexual pain, you alluded to this, is a critical part of sexual dysfunction. And so we do a big disservice to women if we just assume it's that they're just not interested or too busy. That may be true, but vaginismus worldwide, I think it's like 16% of all women report it. That's literally millions and millions of women who have terrible anxiety about the idea of penile penetration. Remember, there are, we believe, 200 million women worldwide who are victims of female genital mutilation. So those women, for starters, often experience incredible pain on sex. Women in menopause have painful sex. Women with endometriosis can have pain with deep penetration. Endometriosis is so common and so underdiagnosed. So when you add all of these things, the 80 million menopausal women, the over billion worldwide menopausal women, if only 70 or 80% of them have genitourinary syndrome of menopause, or the old term vaginal atrophy, that's like 7 or 800 million women who are suffering with vaginal dryness and probably genital pain. And again, that's that's what the people at TED taught me. They're like, "Do you have any idea how many women that is worldwide?" I was like, "No, I didn't do the math." So, it's quite prevalent, and we kid ourselves if we think it's just women who are too busy. Now, it's also that women in our generation and our society are burnt out. They are juggling aging parents and kids who are moving back home and financial things and job things. And they're constantly on Zoom calls and podcasts, and they're constantly on their phones too. So sex becomes a chore, truly, just another thing on their to do list that they have to get through. And I think this is where you and I can hopefully help these women to find the joy in it again. And it may be something as boring as carving out the time and scheduling it and saying, oh, you like to have sex in the morning? How about Saturday morning, 9 a.m., or Wednesday morning, you don't start work till 11, and you make sure, there's lots of ways we can advise people. But the point is that it's also not crazy that just life gets in the way. And when we have to do simple things that don't require an MD, like troubleshoot with our patients, what can you do? Well, if sex hurts, is oral sex a possibility? Is that something you're comfortable with? Is masturbation, is bringing a toy into the bedroom? Oh no, I couldn't do that. It would hurt his feelings. Well, let's talk about that and let's see if we could find a way that you can first get comfortable using a toy. And then I script with my patients all the time. We role play a lot and we talk about what would it sound like for you to say to your partner, I have this toy that I got at Dr. Sophocles' office because my office has beautiful cases full of toys when we go shopping. What would it look like to say, I actually use this because it helps me and I think it's going to make sex more fun for us? Oh, I don't know if I could say that. I might hurt his feelings. Well, we're back to that same darn thing of who is this sex for? You,
Yeah.
him, or both, right?
Yeah. Yeah.
So
Absolutely. So, what are the biggest myths you think you hear about menopause hormone therapy?
the biggest myths are that you can't use it after age 60, that there's this 10-year expiration thing. And when the 10-year buzzer goes off, you have to stop immediately or you're going to get cancer. I mean, I just don't even know how the whisper down the lane happened in that. I mean, we do know that there's less data for women over 65. We do know that. But we also know that aging happens and heart disease happens more and dementia happens more with age. So it's not crazy to think that women, as they age, are going to get these things more commonly. It doesn't mean that hormone therapy causes those things, right? We split correlation and causation. So I think that's a big myth that there's some age thing where we have to immediately stop or something terrible is going to happen. I think the other myth is just the tried and true hormones cause cancer. I mean, we've done an awful job of unhooking that mistruth. If so, I tell people, riddle me this: if estrogen causes cancer, then how come in pregnancy, when our estrogen levels explode through the roof, why don't all pregnant women just get cancer? Why isn't cancer hugely popular in pregnant women? We see the opposite, right? And so that just doesn't make any sense, but it's very hard to unhook that because our fear of cancer is so out of proportion with what data shows as true risk. I think those are the biggest myths. I think the third is family history. My mom had breast cancer, so I can't use HRT. No, your mom's breast cancer does not mean you can't use HRT.
Yeah.
Those are my top three. I don't know if you have some others, but they're my top three.
Yeah, I think, one of the things that I hear a lot is just how women think that after menopause, sex ends, right? A lot of women that, will say, oh, sex, I stopped that years ago, or, oh, I don't need that, or that, well, I'm in menopause now, so I'm not having any sex, like as if the two are
Our
intimately
thing.
related, right? Like as if one thing happens, then the other thing has to happen. And I let women know that, I feel that abstinence is a choice, right? You
Yeah,
decide if you don't
fine if
want to,
it's your choice. Yeah.
right? Like if that's something that resonates with you and you decide that you don't want to have sex anymore, that's fine. But it's not something that has to happen.
And it should be a joint decision. I think some women actually, I'm going to defend men here a minute. They sort of take that decision. Maybe that's what they imagined their mom said, or that's what they believed from somewhere. And so they're like, I guess we're done, and I guess I don't have to do this anymore. And I think that's where this bedroom gap starts widening because the other person on the other side of the bed, if you look at the cover of the book, it's a bed ripped in half and there's roses sewing it back together. But the other person on that side of the bed does deserve a conversation, even if it's to tell him or her, I don't want sex anymore. I don't desire it, and I actually don't want to change. I'm so happy, and as long as you say, like, in fact, I'm happy with our relationship, but I'd really like to remove sex. That's a discussion, and that's a choice. But if that other person's still really wanting it and you're not communicating about it, then that bedroom gap just widens and widens. And the bedroom gap is now actually becoming an official phrase in psychology and taught in graduate schools to graduate students as a concept for a disconnect between couples that revolves around sexual abilities or sexual desires, or expectations rather. And that discrepancy can just keep widening the longer nobody communicates. So obviously communication is critical, even if it's just to say, I'm choosing abstinence. And you know what? Some partners will go, yeah, me too. I'm kind of done. Or I'm having erectile dysfunction and I honestly don't want to take Viagra. Great. I'm so glad we spoke about it. But I think Viagra itself, the launch, did a little number on the bedroom gap. It sort of widened it because it gave men an unfair advantage to be able to not have physiologic issues or solve them, while women who, when Viagra came out in the 90s, remember, nobody was using systemic estrogen. It was just, well, they were, but it was about to be destroyed, right? And so women stopped using estrogen systemically and vaginally. So you had women aging out, right? Getting vaginal atrophy, dryness, loss of desire, and men having the ability to more and more easily get Viagra. And so when I started writing the book, it started as an article for the Atlantic magazine called Viagravation, which I thought was just kind of a cute title, that Viagra was aggravating this whole disparity that was happening in midlife. And I think that still can be a problem for some couples because Viagra is so widely available. You don't even have to have erectile dysfunction now. You can just say, I would just really like more erections. And,
Yeah.
it's almost become a party drug. Whereas vaginal estrogen, we still need a prescription and, all that stuff. So.
Yeah, so let's talk a little bit about your book. We haven't really talked about it. So I'd love to hear, kind of what you hope women will get out of the book when they read it.
Well, I mean, the nerdy side of me hopes they'll really have a better understanding of where these sexual myths and roles and scripts come from, right? That this isn't just you and this isn't just me. This is quite universal that women feel they need to be pleasers and servers and givers for men sexually, and that it really doesn't have to be like that. And especially if you've been in a marriage with bad sex or a bad marriage, or you're widowed or divorced or single, and you're having an opportunity to start a new chapter of your life, or you're just saying, I'm perimenopausal and menopausal, and I don't want to get to 90 and feel like it all just died at 50. If you're any of that, then I think this book is great because I think it's quite empowering to understand where this all came from, why you might be feeling bad for your partner or ashamed that you're even thinking about this. And it's a lot of, so it's how come, but it's also how to masturbate, how to talk to a partner, how to talk to a clinician, how to help the next generation, your daughters or nieces or granddaughters or patients, really advocate for themselves. Everything from consent, which I think should be something we know at any age. Because believe me, if you're internet dating and you're 53, you need to think about consent. You may be dating men who are going to ask things of you that you've never done before. You need to only do what you're comfortable doing and what you want to do. We need to help women of all ages understand consent, understand pleasure. Pleasure. We live in such a productivity focused society. And I think we need to unhook a little bit of that, whether it's screen free time or finding non sexual things that give you pleasure, and then translating that into a feeling of, I would like pleasure for myself sexually. I think those are some of the messages I'd really love women to leave with, that a little education and a little empowerment, and also a little, I guess, grace, giving themselves grace, that you also don't have to go reinvent yourself and become sexually, super active, or master masturbation, or try anal sex if you never have. You don't have to do any of that, but you can. But you can. Just the fact that you're not 25 doesn't mean you can't have actually the best sex of your life. And I hear that quite a lot. And the reason I think is that at 25 or 30, we're so performative. We're so about about showing that we are good at sex, that we're trying to follow all this scripting that we think we know, what we think sex is supposed to sound like and look like. And I think we get to an age where we say, I don't really care about that. I don't really have to perform for anyone. Maybe I don't want to fake orgasms anymore. Maybe I just want to have an orgasm myself. And I get asked that all the time. And it's often women who say, I've been faking orgasms for 25 years. I'd love to not have to do that anymore. So the book has chapters on desire, on arousal, on orgasm, including the orgasm gap, on toys, lube, on using virtual reality for sex, on the history of sex, on a lot of different stuff. I think it's a fun read myself, but always room for one more good book. So I can't wait for yours to come out too.
Thanks. Yeah. No, your book sounds amazing. I'm going to have to start reading it. Just for, those listeners out there that might be Muslim, of course, anal sex is not allowed in Islam, but, we're talking in generalities, and we're talking about people that, all people that may be listening to this podcast and decide that they want to try something different. And I think that's great. I think that, when you read Esther Perel's book about mating in captivity, and she talks about creating that erotic, right? That eroticism in your own relationship, right? Creating that mystery, because that's what she says, is the oftentimes in long-term relationships, she asks that question, like, can you desire what you already have? And,
Men
her,
says it's a lot. I'm sorry. Go ahead.
yeah. So no, I was just going to say that, of course, the answer is yes, you can desire what you already have, but you have to create a little bit of that mystery, a little bit of that space. And I think that, you talking about doing something different, trying something different, right? That creates excitement in a relationship. That creates,
Freshness.
mystery. Exactly. And so that is what's going to keep your long-term relationship going, is that mystery, that something that, is different, that you've never tried before, that creates that and promotes that emotional intimacy also in your relationship.
Definitely, definitely. We talk a lot about that in the book and with my patients. The idea of fantasy, of newness, that many people feel is just not for them. Oh, Harold and I have been married for 30 years. We don't need that. Actually, you and Harold are exactly who need that, because Cheerios are delicious, but eating Cheerios alone for 30 years takes away some of the excitement of it. And so, novelty, fun, um, toys, newness, even kink are things that people, I think, it's okay. And by the way, I mentioned the anal sex because yes, I think your listeners are broad and varied, and because I think that's something that on the internet dating scene, I get asked about a lot. My patients say I'm on Hinge, I'm on this or that platform, and I'm dating, and I'm getting asked this a lot, and it provokes a lot of anxiety because they are afraid to say no. And I think the reason I used it as an example was just whatever it is that someone's asking of you that is not just exciting and new, but a little anxiety provoking, or you're not permitted to religiously, or you had a surgery and it's really going to be dangerous for you to do that. You have to have comfort in saying that's just not for me, or I'm not permitted to do that. And I think that's why I brought that up, because it's such a common example of what I get asked about is how do I tell the person no? And believe it or not, women need coaching and saying,
Of
no,
course.
I'm not comfortable with that. So we
Right.
talk
Right.
about that a lot in the book. I think it might sound very basic. It's not. Women get stuck there a lot. Should I
Yeah.
drop out of the dating scene? No, you just have to learn to just do what you're comfortable with.
Correct. And I agree with you. I think that women, feel like a lot of times they get kind of coerced into doing things that they are not comfortable with, or that they don't want to do, perhaps because they want to please again their partner, right? Or they don't
Yeah.
want to seem like they're too much of a prude, or whatever their reasoning might be. But they, doing something that they're not comfortable with then makes them feel worse about it the next day, right?
Right.
Um,
Right.
so here's some rapid fire questions for you. So what is one thing you wish every OBGYN learned in training?
Oh, uh, hmm, every
I feel like
OBGYN.
there's so many.
Yeah, I mean, just one. I think just to listen better. I read a study where we interrupt patients after 13 seconds. That's kind of embarrassing. I mean, it takes 60 to 90 seconds for a patient to really try to tell their story. So we're so trained to diagnose and treat, diagnose and treat. I don't think we should go in the room going, I got to get to the diagnosis. I think we should pause and let people tell their story, because unless they're getting off on a tangent about their aunt's C-section, we'll learn better where they are as a person, what their needs are. And I think listening, better listening is critical.
Yeah. What do you think is the most underrated menopause treatment?
Better sleep. I think if we can get people sleeping
Yeah.
better, whether it's with CBT, cognitive behavioral therapy for insomnia, and there are apps now, you don't need to go find a therapist. There are apps out there like CBTI, Coach, and Sleepio. I think getting appropriate sleep drives our energy. It drives our sex drive. It drives our eating habits. We crave sugar and carbs less. So I think critical sleep is a menopause treatment.
Awesome. And a wellness trend you think is overhyped?
Well, I think the peptides in general, we have peptides, we use peptides, GLP-1s, and I think GLP-1s are amazing. I've been using them for 12 years with patients. But I think some of the ones with no data that people are just spending a fortune on and trying. I have patients that come in with small suitcases first full of different peptides, chasing longevity. And I am sure some of them will have value. I don't think any of them are dangerous that they're using, but I feel like it's just it kind of exploded into this health optimization trend. And I love the idea of health optimization. I want my patients to be healthy for as long as they can. I think that's more important than being alive for as long as you can. But I'm just not sure that every peptide that's sold is totally valid, because I just think we need more data. I'm sure that's an unpopular answer, but I've got to say it.
It's the perfect answer. And one message you want every woman in midlife to hear?
Oh man, that you have such a long road ahead of you, and that you honestly can look at this as a life chapter, not as a disease process that you've got to get through. Even if you're symptomatic, it doesn't mean there aren't wonderful things, hormonal, non-hormonal, non-prescription, behavioral, tech, devices. We're living in an amazing era, and I love sitting down with patients and really walking them through this and resetting their life at midlife and saying, okay, let's get you a wonderful next 40 years. And they're going, wait, I'm 50, I'm already old. And I'm like, no, you're 50 and you've got great genes and good family history and no significant risk factors. And let's create for you a life of joy and health. And I think it can be that for most people. So.
Yeah, absolutely. If women listening remember only one thing from this conversation about menopause, intimacy, sexual health, what would you want that to be?
The Bedroom Get book has a Bill of Rights, and the Bill of Rights includes the right to comfortable sex and the right to pleasurable sex. So it's really two things. I'm going to slip them in together because they're short, but you have a right to comfortable sex and a right to pleasure. And I think that that's literally, for me, a kind of basic female right that we often don't give ourselves that grace, that right. We don't give it to ourselves.
Yeah. Yeah. Awesome. Well, thank you so much for being on. And so, for all those people that are listening, watching, and thinking, wow, Dr. Sophocles is amazing. I would love to be her patient. How can they get in touch with you? How can they make an appointment?
Yeah, I'm licensed in most states and lots of countries, and I have a website, mariasophoklesmd.com. Maybe we can post it somewhere. They can find me on that website. They can read about the practice and call, I think, what's our number? 609-300-4020. They can check out my TED Talk. I think that's a great way to kind of hear some of these messages in 14 minutes. TED Talk Maria Sophocles. That's the best way, really. My website. You can get the book. You can get the book on Amazon or wherever you get books. 70% of all books are sold on Amazon now. So I try to support little local bookshops. So go to your little local bookshop if you can, because they're struggling. That's the best way to find me. I love what I do. So thank you so much for having me. I've loved talking with you. I feel like we're peas in a pod, and
Yeah.
it's been really interesting for me to learn more from you about the history of the sex positivity. So thank you. That was really cool in the Muslim world. Thank you.
Thanks. Well, thank you for coming on. And well, we are done here, and it's been real and really intimate. Remember, this is not meant to be any type of medical advice. If you have any questions about your health, make sure you go speak with your healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.